Hello and welcome to HCM570. Here we are at the end of week one. I apologize that our live session was technically, I don't know what, it kind of imploded. So I thought I would at least record this for you all so you could all get situated in our course and know what we're really talking about here. Okay, are you ready? Let's get started. First of all, we are talking about healthcare technologies, and I want you to understand that healthcare technology, health information technology, that is an umbrella term. It is not one thing. It is not one software or hardware component. It is the title of the big bushel basket that comprises health informatics. And that is what we are going over for our course this semester. This includes, just to name the most popular and most discussed, electronic health records, EHR, and sometimes you may see this as EMR, electronic medical records. They're kind of different, but for the most part, they are synonymous. Then you have CDSS, Clinical Decision Support Systems. And this is software that's usually hooked up into electronic health records, which provides alerts and, most importantly, direct links to evidence-based medicine, the most recent research and information connected to the condition for that particular patient or prescribed treatment plan or medication or something like that. So this gives a physician, as well as all health professionals, really a fingertip into what's going on today. In the olden days, a physician would have to read every issue of the Journal of the American Medical Association and the New England Journal of Healthcare, and 40,000 others every month in order to stay on top of what is most recent and what is what the newest, latest thing that has been proven to help patients, as well as what may be harming patients. You know, we find out all the time. So this CDSS is now just a link away to help that physician stay current. CPOE, Computerized Physician Order Entry, has been phenomenal since its initial implementation. It has already proven to save thousands and thousands of lives. This enables not only a digital prescription, if you will, instead of the little prescription pad with a scribble on it that nobody can read. Now this goes directly from the physician ordering into the computer and then sent immediately, whether it's to the imaging department or the pharmacy within the same hospital, or it may be to the patient's preferred pharmacy in outpatient. And I personally have had the experience where the physician ordered a medication for me using CPOE while, of course, I was in the office. And then by the time I checked out and got downstairs and into the parking lot toward my car, I got a text message from the pharmacy that my prescription was ready to pick up, which saves time. But most importantly, the real saving is in checking for allergies, for contraindications, and of course the fact that now pharmacists get to have legible prescriptions, so there is no mistake about which medication or the specific dosage or frequency. Okay. Patient portals are excellent for enabling limited access for a patient to get information about their own condition or procedures. It's an excellent way for patients to request copies of their medical records, a refill on a prescription, an appointment with their physician, all online, saving time for in-office staff. It also enables patients to access educational materials such as handouts and flyers and even discussion chat rooms and things like that. And it enables the patient to email or text the physician with questions that maybe they forgot while they were at the office. And I don't know about you, but if you've ever tried to call your physician to ask him a question, between being on hold and, of course, never actually getting to talk to the physician, because you always got to talk to the nurse, then you tell the whole story to the nurse, and the nurse doesn't really quite relay the whole story to the doctor. This is so much more effective and efficient. Also, health information exchanges, which right now are at the state level, and we are, as an industry, working toward connecting all the HIEs around the country to get a national version. But this provides a way for a physician in another system, in another facility, to actually access the medical record for a patient and get it immediately. So, for example, imagine it's Saturday night and a patient has been brought in by the ambulance with the EMTs, and the patient is unconscious. Imagine how much help this is for the emergency room physician to be able to access the entire patient's health record to see, oh, he's a diabetic, maybe he's in diabetic coma, or no, he's not a diabetic. I mean, think about all the time saved and the lives saved, as well as avoiding wasted tests to try and figure out why this patient is unconscious. And then last but not least, and not really last, but telehealth, telemedicine, which again are two terms basically used interchangeably, and it has to do with the audio-visual connection via computer systems between provider, the physician, and the patient, okay? Basically think about it as encrypted Skype, okay, or FaceTime. It's got to be encrypted to make sure we're protecting the privacy and the confidentiality of what's going on with the patient. But telemedicine has already worked tremendous wonders with helping patients get the care they need. Two specific standout subdivisions in healthcare is one, the rural areas where a patient maybe 50 miles from a doctor's office or even 100 miles from a doctor's office. And the other is in behavioral health, mental health. The ability for a patient to use their phone or their computer to talk to a psychiatrist or a psychologist helps them sidestep the concern about being seen walking into a doctor's office. It also helps with avoiding that I have to take time off from work or take a child out of school for therapy. There are tremendous strides being used for this, and they are ever increasing. All right, now we've already had almost a week now of discussion posts, and I want to caution you about what you're using for your resources, okay? Here are 3 excellent health information technology resources where I can guarantee you the information that you get from these websites will be accurate, trustworthy. Keep your eyes on the dates that the document or the website was last updated, so you are sure to be getting the latest and greatest information, the most current information. Remember, you are in school in 2020. You are going to be using this education to get a new job or a promotion in an existing job in 2020 and forward. Arming you with information from 2010 or 2013 that is already outdated, especially when it comes to healthcare technology, is going to make you look uneducated, which is the exact opposite of what you are right now, which is educated, okay? So we want to make sure that the education you are getting here in this course, in this program at CSU Global is knowledge and skills that will help you have a successful year in 2020 and moving beyond, and not retro, okay? This is very, very important, especially when we're talking about healthcare technology, which advances, which innovates at an incredibly fast rate of speed. If you ever have a question about a source you want to use, email me the link and I'll be happy to look at it and give you some feedback, because I want to make sure that you are getting accurate and current information. Okay. Patient safety concerns, and that is part of our conversation this week. You want to look at adverse effects, and there are several different terms that we use with regard to adverse effects. Adverse effect means that the patient is harmed by something arising from medical care. It might be a medication, it might be a procedure, it could be any combination of things, but of course, we don't want that. All right. So the first thing you'll see on this slide, HAC stands for hospital-acquired conditions. So this is something like the nurse or the attendant or the orderly forgot to put the side rail up on a patient's bed. The patient falls out of bed and breaks their wrist. That fracture is a hospital-acquired condition. Of course, we see hospital-acquired infections, HAI, far too often, okay? All right, and then the next two terms, never events and sentinel events, are actually the same things, just two different terms used for the same thing. They're called never events because they should never happen. Sentinel events is a little easier maybe to understand as the term. What it means is it's something that should never happen, such as leaving an instrument or a sponge inside of a patient during surgery and closing them up. That should never, never happen. Okay? Things like that should never, never happen. Yet, we deal with human beings, so unfortunately they do happen. But we all, as healthcare professionals, regardless of what department in the building you work in, regardless of inpatient or outpatient, we all must be alert and aware to do whatever we can to make sure these never events never happen, okay? Now, there are three specific different types of adverse effects. Preventable adverse effects are those due to an error or failure to apply an accepted strategy for prevention, such as having a nurse misread or not read the actual label on the drug about to be injected into a patient, or not checking the chart to see if the patient is allergic. Those are things where there are already strategies for preventing this from happening. and human error. And sadly, it happens, okay? It happens all the time. Somebody grabs it's an emergency situation, and somebody grabs type A blood, A positive blood, and hooks it up to the IV to give a patient a transfusion, and didn't pay attention to the fact that the patient's blood type is actually AB. Very serious. But you got to take that nanosecond to read the label. So that's what we call preventable adverse effect, because there are already protocols to prevent this from happening. It's just somebody didn't engage that protocol. Ameliorable adverse effects are effects that, while not necessarily preventable, they could have been less harmful if care had been different. So this might be a patient who is ambulatory, who is walking to the bathroom without assistance because the patient has been deemed ambulatory, but the patient gets dizzy and falls. So maybe that could have been foreseen, that the patient could become dizzy, okay? So we want to keep our eye out and always be thinking about new protocols that could be taken. And for these adverse effects, the old saying, better to be safe than sorry, should definitely be the quotable quote, okay? And you know, we all do that. We think, maybe I should have a volunteer walk that patient to the bathroom. No, he's okay. He's ambulatory. And plus I need the volunteer to go hand out magazines or something like that. Okay? Go with your first instinct and do that to become a facility culture. Okay? A little bit of paranoia is a really good thing. Okay, and then we have the last and worst, which is adverse events due to negligence. And this is care that falls below the standards expected of clinicians in the community. And, you know, it's understandable that in any organization, people who have jobs don't want to lose jobs. People who have jobs worry about calling out or reporting a person who has more of a leadership role, or maybe has more power or authority. So, you know, you happen to be standing in the scrub in area while the physician comes in to scrub in to perform surgery, and you notice the smell of whiskey on his breath. I don't know. Should you say something? I'm pretty sure you should. So when we think about anything that we may witness or even suspect, I want you to adopt the attitude of, what if this was my child or my parent? Someone that I love more than anything is the patient in this case. And you can do things without necessarily getting fired. Most facilities have 800 numbers where you can report something anonymously. And it takes a lot of courage. I know, I really know. But that's why we're talking about it today, because I want to reinforce and see if we can't build that up in you as you proceed through a successful career. Healthcare will not become better if people who witness weaknesses in the system and do not speak up. Okay. Some of the top patient safety issues that were observed in 2019 have to do with antimicrobial stewardship. And this has to do with specific efforts to make sure that everybody is following anti-infection control protocols. This is so incredibly important, and it also gets deeper. It has to do with a large overuse of antibiotics and other things. So you'll learn more about this in this course, and certainly if you want to on the internet at a credible source, okay? Staff burnout and its impact on patient safety. We all must be aware, especially those on the administrative side. We must be aware and concerned and considerate about clinical staff that might get burned out. Too much overtime, or possibly it's, Gazelda, who has been an RN for the last 40 years. Great. But we want to make sure that she's still enthusiastic, and that she's still on the top of her game. And I'm not saying fire her. That would be foolish. She's got lots of knowledge and experience, but maybe look at giving her a different role, where if clinically she's burned out on patient care, she can take more of a leadership role. You can still take advantage of what she has. And that's another thing about leadership, is not getting rid of when somebody is not good at their job. If it's a good person and a good employee, comes on time, is not absent, you can rely on them, then look at finding them a different department or a different job description that might better suit that person, and therefore continue to allow them to contribute to the facility. Okay? And I think we all, from top to bottom, must continually work at reducing stigma on behavioral health. I mean, come on. Everybody's got stuff. And there are a lot of people who think that if they got stuff, they got to keep it to themselves. Going to a psychologist or a psychiatrist will mark them as crazy. We have to work to reversing that, because the mind, all right, to quote the NAACP, a mind is a terrible thing to waste. And that's not just in education, that's in healthcare. We are all very busy. We make our livings taking care of and restoring excellent function to bones and muscles and arteries and veins and organs like kidneys and bladders and hearts. Why can't we take a more interest in restoring good mental health? That's just going to help everybody. Okay, more quality resources I wanted to share with you. The Joint Commission, excellent information. Becker's Hospital Review. Now, this is a commercial website. You'll notice it's www.beckershospitalreview.com. But it's a well-respected publication in healthcare, so you can kind of believe what they say. They are trustworthy. And of course, AHRQ, the Agency for Healthcare Research and Quality. Excellent sources. I want you to get an excellent education, and you can only do that with excellent resources. All right. We also want to look at, as we investigate patient safety, there are ongoing efforts to reform healthcare, particularly, and I know several of you have talked about, and this is our discussion this week, about medical errors. And so, therefore, we want to make sure, especially those of us on the administrative side, that we are aware of patient safety indicators, that we look at them and use them to create and implement corrective measures, to create and implement policies and procedures within our facility that will make our facility, whether it's a single doctor's office or a large, huge 500-bed hospital, it doesn't matter. A patient is a patient is a patient. And they all trust us. I mean, they're lying there naked in a bed. They are the most vulnerable when they're in our care. And it doesn't matter whether you're on clinical side or administrative side. We are all together as a team working to protect these patients, every one of them individually. Okay, PSIs, which are potential safety, what did I do? Okay, PSIs, they identify potential adverse effects that might need further study in your particular facility. And again, it doesn't matter that you're the new guy or gal, that you're the new person in this facility that's been around for 150 years, or it's been around for 5 years. It doesn't matter. You are there to participate. You are there to bring new, fresh knowledge and observations and participation to that facility. Don't assume that the people who have come before you have already looked at these potential adverse effects, have looked at the complications that occur. And maybe the facility is just now getting technology that can be used to detect these problematic areas or these gray areas. And let's tip the scale now in favor of the patient and patient safety. Okay, research sources. I posted yesterday. I posted this, I hope you think, great information about how to research anything on the internet. I want you to do that because, you know, the school library does not necessarily have the newest, most recent information. And particularly when we are looking at healthcare technology, the source of information should not be more than 3 years old. So that's 2019, 2018, 2017, okay? I want you to look for the most recent. Don't just take the first thing that comes up in Google. You have to discern what the trustworthy, credible sources are. Then look at their dates. Just watch my video. It's not very long, but it will definitely improve your ability to gather current valuable information and make sure you're walking out of here with a 2020 valued education and not one from 2013. Okay? All right, what questions do you have? I know you may have some, or even if you want to elaborate, talk about something a little further, email me. I am in the course every day, 7 days a week, rain or shine. I know it's online, so that shouldn't matter, right? Okay. Even if there's a snowstorm, which honestly may be possible in Colorado, but the secret is I'm in Florida, so unlikely. I am here for you. I promise you a response within 24 hours. I'm your coach. I'm your Sherpa. I'm here to help.